I will start with this case presentation. This was a 23-year-old female who complained of disfiguring ocular deviation. And she gave a history of previous surgery for congenital glaucoma at the age of 1 year. She had bilateral moderate ptosis, best corrected visual acuity with 0.6 in the right eye and 0.9 in the left. Slit lamp examination showed a right cystic glaucoma bleb, a right peripheral pyridectomy, and her cup discretion was 0.5 in the right and 0.3 in the left. So this was her general examination. Now, this is the ocular motility examination. In the primary position, there was an exotropia, 30 prism diopters, and a right hypotropia of 14 prism diopters. And when she looked to the left, there was -3 limitation of adduction, lid retraction, and more hypotropia or depression of the right eye. There was -3 limitation of elevation in straight up gaze, -3 limitation in up gaze and adduction, but with globe retraction, and -3 limitation in abduction as well. So, and there was also an X pattern exotropia. So I looked at this case as an atypical Duane syndrome case, and just to summarize the findings, there was exotropia in primary position and hypotropia, which increased in adduction. The hypotropia increased. Right lid retraction on adduction with limitation of adduction, and right limitation of elevation with globe retraction on elevation and adduction. So in thinking or formulating the surgical plan for this, I thought there was hypotropia, which was attributed to inferior rectus anomalous innervation. Therefore, I should go for an inferior rectus recession. There was the exotropia, which has to be dealt with, and therefore I was going to add a lateral rectus recession to the inferior rectus recession. So this was my initial surgical plan. So on table, the first thing I did was to perform force suction test for the inferior rectus muscle and for the lateral rectus muscle. And there was a mild restriction to passive elevation of the eye and a more restriction to passive adduction of the eye. So I started by the lateral rectus muscle. I secured it on 605 with suture. Disinserted from the globe, repeated the force suction test, but it remained the same. It was still very, very tight. So I decided to explore the inferior temporal and supratemporal quadrants for fibrous bands or accessory muscles. And I found an accessory muscle that was present in the supratemporal quadrant. The insertion was behind the equator. It was just above the lateral rectus muscle, and the origin seemed to be coming from deep within the orbit. So I disinserted the muscle, and immediately there was a great improvement in the adduction. I recessed the lateral rectus muscle because it was still a tight muscle, and then I stopped to think, should I go on and recess the inferior rectus muscle, which was my original plan, or should I not recess it? And I stopped there for a while and started to think about how was the accessory muscle contributing to this deviation? What was its effect? So, by looking again at the insertion was posterior to the equator in the supratemporal quadrant. On the right-hand side, the arrows point to where it was coming from, and it was coming from deep in the orbit, but again, still in the supratemporal quadrant. So, how was it contributing to the deviation? Because it was inserted posterior to the equator, it was causing the hypotropia in primary position probably, or contributing to it. On attempted adduction, anomalous innervation caused the limitation of adduction and the more hypotropia that was occurring when this muscle contracted. And it was also acting as a reverse leash that was causing limitation of elevation. So I decided not to go for inferior rectus recession. I decided just to wait and see what disinserting that muscle would do, plus the lateral rectus recession. So this is how I changed my plan. Force suction test for lateral rectus and inferior rectus muscles was positive for the lateral rectus. This is why I started with that muscle. Disinserted it, and always you should repeat the force suction test after you disinsert the muscle. It was still positive. This is why I started looking for fibrous bands and accessory muscles. Then there was release of the accessory muscle, which reversed the force suction test, and therefore I decided not not to operate on the inferior rectus. This was the post-operative appearance of the patient. In primary position, there was actually a small hyperphoria in primary position in that eye. On looking to the left, there was no depression of the eye in adduction. There was improvement of the limitation of adduction from -3 to -2, but I still had the limitation of elevation in upgaze, in all upgaze positions. And there was collapse of the X-back. So, why was there still persistent limitation of elevation after surgery? Because the accessory muscle may have reattached to the globe, and I think that this was my mistake. Instead of disinserting it, one should excise part of it, and that will maybe cause it to retract further back. There could be other innervational anomalies or other accessory muscles or bands that were not easy for me to find or were more posterior and therefore inaccessible. So let's just take a look at what is typical vertical vein syndrome. That looks like there's limitation of elevation or depression, globe retraction, and palpebral fissure narrowing. The affected eye may be orthotropic, hypertropic, or hypotropic. And this is caused by innervational anomalies, fibrosis of vertical rectus muscles, a tethering effect of horizontal pipe muscles, or fibrous bands and accessory muscles that restrict elevation or depression. This is what a typical vertical vein syndrome looks like. There's a small hypertrophy in primary position, globe retraction, and narrowing of the palpebral fissure on adduction and abduction, limitation of elevation, again, with globe retraction on elevation. But this was, again, my case was an atypical case. So Luder described 3 types of anomalous orbital structures that one can meet. Either an anomalous muscular structure that arises from extraocular muscles and inserts in abnormal locations. An anomalous structure that arises from posterior orbit, which is what I had, and inserted in an abnormal location on the globe, or fibrous bands, which are usually located beneath the extraocular muscle. This is again another accessory muscle, which I found inserted just above the lateral rectus muscle in another case. Accessory extraocular muscles usually are a unilateral finding. You can find more than one in a case, in the same eye, but sometimes they can be bilateral. They can be regarded as an additional component of congenital cranial disc innervation disorders. And Deemer suggested that they can represent aberrant muscle tissue that was either never innervated or lost innervation during development. It results in unusual patterns of strabismus with restriction of eye movements with or without globe retraction, and most commonly reported between the levator pulvinar superioris and the trochlea, between the levator and the globe, between the inferior rectus and the globe, or as an accessory lateral rectus muscle. 1 minute, please. I'm almost done. So how to manage atypical vein syndrome? Orbital imaging is very important. I didn't do it in my case. She was coming from out of town, had no medical insurance, and very limited money. But orbital MRI now, with the high resolution MRI, can identify accessory muscles. Always repeat forceduction test after disinsertion and careful exploration. It's better to resect than disinsert accessory muscles. You may need to weaken a muscle that's causing limitation. Relapses can occur by reinsertion of accessory muscles, and always be prepared for surprise.